So the postpartum period. The postpartum period begins with the birth of the baby, comprises both physiological and psychological components, and lasts for approximately about 6 weeks. During this period, the reproductive organs recover from the pregnancy and deliver. In general, this time period is the physiological stabilization of the mother's body to the pre-pregnant state. Psychological adjustments to the birth of the new baby may take longer than 6 weeks, and during this time, the maternal bonding with the infant begins to occur and the maternal depression may emerge. This is the time period where the mother and infant need the assistance from healthcare workers and family to ensure that successful transition and that successful bonding that we need to see. Physiological changes. So one thing that we start off with is the uterine changes. It's called uterine involution. The uterus contracts after expulsing the placenta to prevent hemorrhage from the placental site. The uterus is transformed from a womb weighing over about 2 pounds to 2-ounce structure once involution is complete. So it starts out heavier, about that 2 pounds, and it goes down to 2 ounces. This process takes about 6 weeks. Then we have the endometrial regeneration. The lining of the uterus or the endometrium is shed in preparation for regeneration and restoration. The area where the placenta was attached takes the longest time to actually heal. A discharge known as lochia results as the surface of the inner uterus heals. So we have that lochia. Lochia, initially the lochial discharge is the lochial rubra, which is very red. So that's right after birth. It starts out very red. And then it becomes a lochia serosa, kind of like a brownish color. And then finally the lochial alba, which is like a pale or light brown. The discharge generally subsides about 6 weeks after delivery. So it starts off very rubra and ends up very brown colorish. So question, a discharge known as lochia results as the surface of the inner uterus heals. This discharge changes color and lasts for blank after the birth of the baby. So the answer is B, 6 weeks. Rationale, initially the lochia discharge is that rubra red, and then it becomes that cerucosa, and finally the alba, which is that pale or brownish color. And the discharge generally subsides by 6 weeks after delivery. So your postpartum assessment, this is where we talk about the bubble HE, and this is a maternal assessment that's done on all postpartum moms. So a good way to remember it is by just the bubble HE itself. And so the first B starts out as what you're looking for is the breast. So you're looking at size, shape. Are they engorged? Is your breast red or the nipples cracked? All those things, so you're assessing that breast area for anything that's abnormal. The U is the uterus. And here we're looking at, we'll be feeling, and we'll go through this more later out in the PowerPoint here, but you're looking to make sure that that fundus is firm and not boggy, because remember, boggy can allow us to hemorrhage, so we want to make sure it's firm. If it's not firm, we're going to massage that fundus until it is firm. The B, the second B, is bladder. So is it emptied? And we want to make sure that the bladder stays emptied all the time, because that allows that fundus to clamp down and get back into place. If we have a full distended bladder, that kind of pushes that uterus up and doesn't allow it to contract down and to stop the hemorrhaging. The next B is when was their last bowel movement? And remember, with this and with having a baby and things like that, that area becomes very sore. And so a lot of women don't want to have a bowel movement because maybe they had an episiotomy or some of those things that make that area very sore. And so the last thing they want to do is have a bowel movement. So we want to make sure that we keep the bowels very soft for the patient, and we also make sure that we keep the bowels moving so they don't become hard and impacted. So we want to know their last bowel movement. The L is the lochia. So again, we're looking at the amount. Is there an odor? There shouldn't really be an odor. If you do smell an odor, we're looking at possible, signs of infection. The color, and we just kind of went through that. What color is it? The clots, anything over a quarter-size clot should be reported to your provider. And we want to know how often they're filling a pad, how much is in their pad, because if they're filling over a pad an hour, that is a concern for hemorrhaging also. The E is episiotomy. So here we're looking at the location. Did they have stitches? What degree of episiotomy was there? So there can be up to like a 4th degree. So it can go anywhere from 1 to 4. 4 extends into the anal area. So it is an actual tear like that extends into the anal area. So we want to make sure we're looking at the location. Was everything stitched up? We're looking for any signs and symptoms of infection. Is there edema? Also, we'll be putting ice on this area to help with any of the swelling and kind of torment from the labor itself. The H is the Hohmann sign, and you can see over here on the right, the Hohmann sign, it's a positive Hohmann sign if it's indicative of a DVT. So what we're looking for is, do they possibly have a DVT? Now think about it. A mom is up in that lithotomy position for long periods of time. They're pushing. Remember from when we learned back in one of our very first chapters, the mom has twice as much blood, so that puts her at more risk of DVTs. So we're looking, do they have any signs and symptoms of redness? Those type of things. The patient's leg is positioned at a 90-degree angle, either while supine or sitting. The dorsiflexion of the foot reveals pain in the calf if it is positive. But remember, the Hohmann sign isn't all that we're looking for. We're looking for other signs of a DVT, redness, sudden pain, like sharp pain, or warmth in the leg area, all those different things we're looking for. Okay. The last E is for emotions. And so we're really looking for, postpartum depression can come on very sudden, and it also can come on later. So we want to make sure that we're establishing that emotional status, the bonding with the baby. But while we're doing this, we want to make sure we also keep in mind that cultures are different from other cultures too. And so sometimes like even for if you're dealing right with the Hutterite population, that mom might not bond with her baby like a normal, what we consider to be a normal bonding. They have very much support groups, so they might have a group of 4 to 5 women that come in and totally take care of the baby. So just kind of assessing what's normal for their culture, making sure that they have the resources and to know that postpartum depression is very common because of the hormonal fluctuation that happens right after birth. So just education, education, education. So we have what's called uterine involution. So this is the return of the uterus to its pre-pregnancy size and condition, which begins immediately after the expulsion of the placenta with contractions of the uterine smooth muscle. So you can kind of see on the chart there the fundal height at delivery. It's above the umbilicus, and each day it should progress down to where it's back behind the pelvis. So immediately after birth, the uterus is in the midline, approximately 2 centimeters below the level of the umbilicus. It's about the size of a grapefruit, like 16 weeks of gestation, and it weighs about like that 1,000 grams. Within 12 hours, the fundus may be approximately 1 centimeter above the umbilicus. And so it kind of goes up, and then the next few days, the fundus descends, okay? 1 to 2 centimeters fingered is every 24 hours. So by the 6th postpartum day, the fundus is normally located halfway between the umbilicus and the symphysis pubis. A week after birth, the uterus once again lies in that true pelvis area. And after the 9th postpartum day, the uterus should be not palpable abdominally at all. So every day, it goes up just initially, and then it'll come down every day after, okay? Remember, the clamping of the uterus is what stops the postpartum hemorrhage. So we want to make sure it's clamping down and going back into its normal state. So we'll talk about the perineal and breast area. So perineal swelling and engorgement and edema are common in the first few weeks after delivery. Remember, we have a lot of when we're pushing um, the fetus out, like there is just a lot of pressure there and a lot of engorgement in that area. So you'll see that there's a lot of edema. We use a lot of ice packs postpartum to try to help with that edema. They also put on like ibuprofen and stuff to help with that swelling and edema also. There also may be an episiotomy or lacerations or bruising in the perineal area. Vaginal dryness may cause discomfort with intercourse until hormonal actions enhance natural lubrication, and this usually occurs once ovulation resumes. But do remember, any mom that is sent home, they are told not to have sexual intercourse for like 6 weeks. And that's to allow those things to be put back into place. It also allows healing of like episiotomies or tears. And it also just allows for hormonal changes to go back to normal. And by that time, you'll be into that, ovulation will be resuming. Breasts. Throughout pregnancy, the breasts have been preparing for that newborn. So the areolas become very darkened and colostrum filled, the precursor to breast milk. So that colostrum comes first. That's the very little bit that the baby gets right away when they start to nurse. And then that actually kind of starts bringing the milk in. Engorgement of the breast occurs on or about that third day after delivery, and the colostrum becomes milk on the third to fifth day. So, again, just watching for that engorgement on the breast. We also want to make sure we watch that the baby latches appropriately if they are going to breastfeed. The reason that is if they don't get that. When you think of like sucking on a little nipple, we don't want them to suck directly on the nipple. We want the nipple to be towards the back part of the tongue so that they're getting a good latch. If the baby is just on the nipple portion, your nipples will become very cracked, very sore. They'd have to work that towards the back to actually get a perfect latch. Now let's talk about like even if your mom has some inverted nipples, there is different shields that they can wear that'll help pull that nipple out and give a shield so those nipples don't become cracked and sore. So those are all different things that you can, the nursery will have to help with breastfeeding. Even if the breast dents aren't perfect for breastfeeding, we can help with adaptive things that will allow that breast to be there. Did you know that colostrum is low in fat and high in carbohydrates, protein, and antibodies? It is extremely digestible. It's low in volume and highly concentrated nutrition. The colostrum has a laxative effect on the baby, helping pass early stools, which aids in the excretion of excess that bilirubin and help prevent jaundice also. So obviously the colostrum has many mechanisms in it and is one of the best things for the baby right after delivery. Okay, so again, just make sure you're watching those breasts. They are also very at risk for like mastitis and some of those things. If your mom does not plan on breastfeeding, we encourage them to put on a very tight bra and wear it 24 hours a day for like at least 10 days to kind of help that engorgement feeling and help so that the breasts don't become so engorged with milk. Cardiovascular. During pregnancy, the blood volume increases, which we've talked about, and it drops during delivery and stabilizes within about 2 weeks after delivery. So you're kind of back to that state prior to delivery, about 2 weeks after. Approximately about 500 milliliters of blood is lost during a vaginal delivery, and about 800 to 1,000 millimeters during a cesarean section. Normal diuresis following delivery adds to the decreased volume. Obviously, delivery, you're working very hard. It's kind of like running a marathon. And vital signs remain stable during this time unless blood loss is very extreme. So again, we're always watching our vitals. That is one of the main things that can tell us how things are going. Even after delivery, you're doing that postpartum assessment with that bubble heat, and we're making sure we're taking vitals as part of that to make sure that our mom is stabilized. Gastrointestinal. Bowel changes complaints are common after delivery. Constipation often results due to decreased activity. Also, you're usually on some pain medication. We just have decreased GI motility and perineal hemorrhoidal or incision pain. So, again, you're just kind of holding that in. So, we want to make sure that we relieve constipation very early in our patients. We're encouraging like a high fiber diet, encouraging a ton of fluids, not only for GI, but for milk production and stability of our patient. Ambulating early and frequently. We want to make sure we're teaching those Kegel exercises and relaxation techniques and obtaining any orders for stool softeners or laxatives as needed. So it's very, very common for all pregnant ladies to be on a stool softener after delivery, whether that be regular delivery or C-sectional delivery. We're also watching for urinary tract infections. Birth can damage the urethra and cause swelling of the perineum, which can make urinating very difficult. So think of it, obviously, if we're getting an epidural, we're also probably getting, during that time frame, we're going to be getting a catheter placed in. So obviously, that's a place for induction of infection, those type of things. We also like I said, there's a lot of swelling and things, and sometimes those parts with the swelling don't work as good as they should, so we're making sure that we're watching that. So we want to make sure our assessment of the bladder emptying is essential, very, very essential during the postpartum period, as urinary retention can interfere with that uterine involution and ultimately to postpartum hemorrhage. So keeping that bladder empty is very, very important and one of the most important things after delivery. The use of a bladder scanner can also help us assess the status of the bladder. If the patient cannot void spontaneously or does not completely empty the bladder, intermittent catheterization may be necessary because it is very important that we keep that bladder empty. So the menstrual cycle. Huge hormonal changes begin with the expulsion of that placenta. With dramatic fall in the levels of estrogen and progesterone, the uterus begins to contract and volute, and so by that 6-week postpartum, it will have returned to its position behind that pubic bone. The involution may cause some discomfort and is referred to as the afterbirth pains. Walking, emptying the bladder often, pain medications, breathing and relaxing techniques help lessen that pain. So just kind of watching for that hormonal changes, and it will kind of within about 6 weeks, you'll be back into your normal menstrual cycle. So postpartum hemorrhage, this is one of the main things we watch for during the postpartum period. So the postpartum hemorrhage is excessive bleeding in the early postpartum period and is actually responsible for 25% of the 515,000 maternal pregnancy-related deaths. Postpartum hemorrhage is defined as the blood loss that is greater than 1,000 milliliters and or the need for a red cell transfusion. There are 2 classifications of the postpartum hemorrhage. There's early, which is developing in the first 24 hours, and then there's late, which is developing after the first 24 hours after childbirth. Some things like retained placental fragments are the most common cause of late hemorrhages, and the major cause of postpartum hemorrhage is uterine autonomy. So that means that uterus is just not clamping down like it needs to. And again, if you go in and assess that patient for that bubble heave right after delivery, and if that fundus is not firm and you notice that the patient is losing a lot of blood, you need to rub that fundus and massage that fundus until it is firm and call for help immediately. Uterine autonomy is defined as failure of the uterine muscle to contract normally after the baby and placenta are delivered. And uterine contractions facilitate vessel compression, which in turn stops that bleeding. So as that clamps down, we're trying to stop that bleeding. When uterine contractions, when the uterus does not contract enough, bleeding continues. A floppy, uncontracted uterus results in significant blood loss. And remember, whether I'm bleeding from the vagina or I cut my arm off, hemorrhage is hemorrhage, and you're going to treat it the same. Factors that may prevent the muscle of the uterus from contracting is prolonged labor is one, so it just gets really stretched. It's tired. It's kind of like running a marathon. It's tired. It doesn't want to clamp down. We can use the use of oxytocin during labor. So again, we've really contracted that uterus to expel the fetus, and it's tired. General anesthesia can also be a contributing factor. And again, anesthesia, what does it do? It relaxes the muscle, puts the muscles to sleep. And so again, it's just getting that tone back. If we have twins or multiple births, anytime that we stretch that out farther, it's hard to go back into place. And then we have that polyhydramnios, which is that large amount of amniotic fluid. That's another cause that can be for the uterus not going back in place. A large baby or history of more than 5 pregnancies. So just think, if that's been stretched out that many times, it doesn't have a lot of tone to go back into place. If there's an infection, that's another thing, or placental fragments remaining in the uterus. Those are all things that can kind of really cause some issues of that placenta, or excuse me, not the placenta, but the fundus going back into place. So, question. Postpartum hemorrhage is defined as A, blood loss greater than 5,000 milliliters, B, the need for fresh frozen plasma during the early stage, C, blood loss greater than 1,000 milliliters, or D, the need for red cell transfusion within the late phase. It's C. Postpartum hemorrhage is defined as blood loss greater than 1,000 milliliters and or the need for red cell transfusion. There are 2 classifications, remember, so of postpartum hemorrhage. It's early, which is developing in the first 24 hours, and then there's late, that's developing in the first 24 hours after childbirth. So we have postpartum hemorrhage risk factors, and we did talk about this a little bit already, but some of these are the risk factors for postpartum hemorrhage. If you're Asian race, if you have maternal blood disorders, if you've had prior postpartums, if you had a large baby, retained placental fragments, multi-pregnancies, if you have a tract lacerations, antepartum or interpartum, you have hemorrhage, labor induction, episiotomy, stillbirth, anesthesia, prolonged labor. If there was forceps that were used after delivery, that can cause lacerations also, or even a vacuum. So those are all postpartum hemorrhage risk factors. And if you think about that, that's many of our clientele is included in these drop-down menus. So what are we going to do for management of postpartum hemorrhage? And this is very important, because anytime that you are assessing on the floor for the postpartum patient, you are assessing for hemorrhage. For the first treatment of postpartum hemorrhage is a fundal massage. So again, finding that fundus and massaging it until it is firm. Fundal massage should be performed until the uterus is firmly and it is contracted down. When fundal massage is not effective or bleeding is excessive, IV oxytocin or other uterine stimulants may be necessary to manage to really contract that uterus down. Blood product administration is based on hemoglobin and hematocrit results and the patient's stability. Other causes of postpartum hemorrhage include genital tract lacerations. So again, like those episiotomies, or if there was a tear, vaginal or pelvic hematomas. Remember, we're pushing, and that can cause tearing and hematomas in that area. Uterine rupture or even abnormal placental implantation. Those are things like that can really cause postpartum hemorrhage. But again, you got to massage till the fundus is firm. If you notice there's a lot of bleeding, you're going to call for help. You also can administer like IV oxytocin. So if they have Pitocin running, you can increase that amount to try to get that uterus to contract. Otherwise, we might even have to go into some pharmacology drugs. And so some stimulants that can be given, and you'll want to know these. So Pitocin, another drug that we use quite often is Methergin. those type of things to get that uterus clamped back in place. Now, something I do want to tell you with Methergin, make sure you're always looking these drugs up in the drug book, because here's the thing, most of these are back in the labor and delivery cabinets. The doctor might order out, give Methergin stat, that type of thing. So we want to make sure we know how to give them. I'll give you a prime example of this. I was working in the OB, and actually there was a new nurse on, and one of the doctors ordered Methergin stat, and she went and drew it up. Said, okay, I'm going to give Methergin stat through the IV, and he caught her saying that and said, no, 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 it can only be given IM. Like, he would have coded, or if this patient would have, or if this nurse would have given this patient that, she would more than likely have coded and probably died. So make sure that you know how to give the drugs that you're giving. So Methergin is one that we give IM. A lot of times we'll give it right into the thigh muscle, because if you think about it, OB is, you're accessible. That area is accessible. It's easy to give. That's kind of a normal area to give that in. And a lot of times they might even tell you just to open the Pitocin up. And so you're running the Pitocin as fast as you can in, and to get that contracted. And it might be something you're doing simultaneously to do. Okay. So again, continue to massage the fundus. Make sure we're giving drugs that will help contract and that we're giving them in the right way. And then we can also, we'll be watching blood pressure and some of those things. So think hemorrhaging, what some signs and symptoms that your patient are going to have. They can be sweaty, their blood pressure will decrease. They can kind of have short of breath, all those things that hemorrhaging can bring along with that. So you might even have to lay them down and put them in like a Trendelenburg, anything like that, we can to help control the blood pressure and things like that. So psychological adaptations. The nurse plays a significant role in promoting mother and infant bonding and can positively impact new mothers' self-confidence by praising and reassuring them of their competence and ability to care for their newborn. Many moms, whether they be new or this is their second baby, many people feel incompetent and that we aren't able to take care of this baby correctly. Bonding with the infant after delivery is critical to the parent-child relationship. Behaviors such as eye contact, holding, touching, smiling, talking to the infant are all part of the attachment process. It is important to remember that this important bonding process is interrupted when the newborn infant must be whisked off to the newborn intensive care unit, or even if the nursery for care for immediately after birth. So it's kind of like sometimes if they need that extra special care, that bonding process kind of gets interrupted. So we want to make sure when that baby gets back that bonding process, continues even after they're back. Postpartum baby blues. This is incredibly changes in the hormonal balance along with the alterations in maternal physiologically can leave postpartum women feeling very anxious, teary-eyed, overwhelmed, depressed. There's like an emotional kind of roller coaster. These feelings are commonly referred to as postpartum blues. They usually emerge on the second or third postpartum days. If you think about that, when do we send moms home? That second day, even third day. So we might not see that in the hospital. So we want to make sure we're educating the family of what to watch for and the patient also. Usually it resolves spontaneously within a few days to no longer than 2 weeks at home. But think about it. When we go to send this mom home, the next time she's probably going to see her OBGYN is like 6 weeks. So who does she usually see first? Yep, the pediatrician. Usually they see the pediatrician back in about a week. So there's been a lot of correlation where now that the pediatricians are asking the mom certain things to kind of monitor that depression and if that things are going well at home, because they might not see their OBGYN until 6 weeks down the way. Postpartum blues usually affects 50 to 80% of new mothers. A new mother can have sudden mood swings, sadness, crying spells, loss of appetite, sleeping problems. She might feel irritable, restless, anxious, lonely, because if you think about it, they stay home with the baby, and a lot of times you might not see somebody for a long time. So It can become very lonely. You can become very overwhelmed. Your baby's not sleeping. Your milk's not coming in. There's just a lot of different emotions that are happening. Symptoms are not severe and treatment is not necessary for all cases. The blues do not interfere with the mother's ability to care for herself. And that's the thing. If the blues start interfering where the mother can't care for herself or the baby, that's when we intervene. A lot of their lives, a lot of these things will like kind of necessarily take care of themselves. Um, it's considered a common and expected reaction to the delivery of the baby. It is not considered an illness, nor is it related to any previous mental illness, and is not caused by stress. It's just very hormonal. Now, that's the blues, but postpartum depression is one of the categories of postpartum mood disorders affecting about 10 to 20% of new mothers. It is a major health issue and well documented negative health consequences for the mother, child, and family. It may not be easily identified and therefore often goes untreated because, again, kind of like I was talking, they don't see somebody for a while and it might not be caught on that pediatrician visit or it might not be caught for like 6 weeks. It can happen at any time that postpartum depression can within the first year after childbirth, so it doesn't have to necessarily be right after. A woman may have a number of symptoms such as sadness, lack of energy, trouble concentrating, anxiety, and feeling of guilt and worthlessness. But sometimes think of lack of sleep, in which obviously many newborn moms have lack of sleep. This is kind of hard to diagnose at times. Where it becomes a problem is the woman's well-being and keeps her from functioning well for long periods of time. That's when it needs to be interfered in with the doctor. So early recognition, counseling, support groups, and medications can all help with postpartum depression. Risk factors for postpartum depression. Women may have a higher chance of postpartum depression if they have a history of a mood or anxiety disorder prior to pregnancy, have had depression with a previous pregnancy, have a close family member who has had depression or anxiety, have anything particularly stressful happening on during the pregnancy, including illness or deaths or anything like that, a difficulty of an emergency delivery or preterm delivery or illness. Those are all type of things that can affect your postpartum depression. If they're over the age of 30 or if they are in their teens, they're more at risk for postpartum depression. And obviously, if they have a pregnancy that is unplanned or unwanted, those are all at risk too. So, and if they've had alcohol abuse or take illegal substance or smoke, that makes them at higher risk for depression also. So, risk factors for postpartum depression include which of the following? A, abuse drugs. B, are in their teens. C, have a history of mood disorder. Or D, all of the above. D, all the above. Women may have a higher chance of postpartum depression if they have a history of that mood or anxiety disorder, have had depression, have a close family with depression, are in their teens or over 30, have had a pregnancy that's unwanted, or if they abuse alcohol, take illegal substances, or smoke. Those put them at higher risk. So, postpartum depression management. Postpartum depression can happen to any woman giving birth. It's not something that specifically puts you at risk and says, yes, you will have postpartum depression. Any woman that gives birth can have postpartum depression. Unfortunately, a stigma is attached to mental illness. Therefore, some women don't tell anyone about their symptoms because they are afraid to be diagnosed with depression. They feel embarrassed, ashamed, or guilty about feeling depressed when they are supposed to be happy because they're taking this baby and they've had this brand new baby and they're supposed to be happy and they're not feeling happy, so they feel a lot of guilt. They worry they will be viewed as unfit parents, that they're not good enough, those type of things. It is very important that nurses encourage new mothers to seek assistance if they are having signs and symptoms of that postpartum depression. And we want to make sure we're educating the family also, because sometimes the family are the ones that actually see it before the patient does. Healthcare workers should screen all new mothers for the risk of postpartum depression. There are several questionnaires available to assist the healthcare providers screening for that. If postpartum depression is suspected, there are various treatments and modalities that can help. And individuals in group, like talk therapies, can help women that have postpartum depression feel better and do better as a mother and as a person also. It's a very crucial component of postpartum discharge teaching is information regarding postpartum depression, signs and symptoms, and how to assess and help should there be concerns of developing postpartum depression. Untreated postpartum depression, there's lack of energy, you can have trouble concentrating, irritability, and an inability to meet the child's needs for love and affection are all signs of postpartum depression. The depression can worsen as the mother loses confidence in herself as a mother because she starts feeling even worse about herself. So the depression can even show more symptoms and be more severe. Postpartum depression may cause delays in language development, problems with emotional bonding, behavioral problems, lower activity levels, and sleep problems even within the infant. These delays may be mitigated with the help of another caregiver. So if we're seeing that a mom's really, really struggling, sometimes we'll ask if there's somebody that can come stay, like with a caregiver, that type of thing, to help just with that extra bonding. Excuse me. Postpartum psychosis. Postpartum psychosis is rare. It occurs in 1 or 2 out of every 1,000 births and usually begins in the first 6 weeks postpartum. Women who have bipolar disorders or another psychiatric disorder have a higher risk of developing this. Symptoms may include rapid mood swings, delusions, hallucinations, sleep disturbances, and obsessive thoughts about the baby. So postpartum care. We're going to talk a little bit about a lot of different things in postpartum care and what to look for. So we'll start off with the perineal care. Perineal tears are very common during the birth of the baby. In addition, episiotomies are often performed to allow additional space for that baby to be delivered and prevent that uncontrolled tearing. So we'd rather think about it. We'd rather have the doctor do a nice clean cut of an episiotomy. It's easier to sew back together, promotes healing, those type of things. Then if we allow a tear, if you think of a tear, it's more jagged edges, harder to place that back together. So anytime they can do an episiotomy, it's easier on the mom, it's easier for healing, it promotes faster healing, all those things. These tears and cuts can cause discomfort in the early postpartum period. During this time, the perineum should be kept as clean and dry as possible to allow for healing to occur without any infection. Postpartum women who are ambulatory should be taught to perform perineal care after using the bathroom and instructed to the importance of frequently changing like their sanitary towels to maintain a clean and dry perineum. So we want to make sure that they're if they can't wipe, there's things called like a little peri bottle that would like you squeeze and it shoots water up there. So we want to make sure it's getting cleaned properly, even if you can't wipe. Otherwise, we just like pat dry in that area. We'll even encourage like some sitz baths, some of those things. We can put like witch hazel right up and next to the perineum area, so it promotes that coolness, kind of that little feeling of, I don't know, like a cool feeling that kind of helps promotion. We'll also do like ice pads to help with the swelling, all those different things, just to try to keep that area clean and promoting healing within that area. There are a number of methods used to relieve that perineal pain, including cold baths or ice or cold packs, following your organization's protocol for providing perineal pain relief. But several studies show that excessive cooling may possibly delay healing or cause ice burns. So we just want to make sure like that if we're using like ice packs and stuff like that, that we're not putting them directly on the skin. Just watching and make sure we're promoting that area to heal properly and things like that. Regular sitz baths can be effective in reducing that perineal pain by increasing blood flow to the perineum and keeping that area clean. Postpartum patients can also be taught to squirt warm water over the perineum during and after urination to ease that perineal pain. Again, not the wiping that we promote, but more just keeping that area clean. Then you can kind of pat that area dry also to keep it dry. Postpartum infections. The most common postpartum infections are urinary tract infections, endometritis, and wound infections. Prevention is the key. So, effective hand washing can help to prevent many of these infections. Clean hands are the single most important factor in preventing the spread of pathogens and antibiotic resistance in healthcare settings. UTIs, they occur in the postpartum patient, 5% usually, and are more frequently anytime the patient has been catheterized either before or after delivery. So make sure that we're using that sterile technique when we're putting those catheters in, preventing those urinary tract infections. Endometritis occurs when the lining of the uterus becomes infected. Symptoms would obviously include your fever, chills, abdominal pain, or foul-smelling lochia. Wounds, they occur in the genital tract, like the episiotomy or cesarean section, incision, maternal. We want to make sure that we're washing anything for infection. Management of postpartum infections. Utilizing any evidence-based practice prevention bundle can prevent urinary tract infection. Good hand washing, sterile technique during catheterization, and searching for actual need rather than convenience. So is it a need? That type of thing. And removal at the earliest convenience are all parts of prevention bundle. So as soon as we don't need that catheter, get it out. Those type of things. Obviously, antibiotics and those type of things may be ordered for unidentified wound infection. Then we also talk about thrombophlebitis. So, that is inflammation of the vein wall, and a thromboembolism is a clot formation. Women are obviously at increased risk for the thrombosis after delivery as the result of the venous stasis due to uterine pressure and that hypercoagulability also. It's a disease is more likely to occur after cesarean birth, so anytime that we do a cesarean, we're at more susceptibility. The patient may complain of fever, and her leg may be swollen, painful, or discolored. So symptoms often appear on the third or fourth postpartum day. So again, really educating, because a lot of these patients are going home about that. And so we want to make sure we're educating them. Even to when we talk about the hemorrhage, they should be able to feel their own fundus and to massage. It is very common for women to go home and realize that they're bleeding more, and when should they call in? If they're soaking a pad an hour, that they need to notify the provider immediately. Same with this, that fourth postpartum day, but it might not even occur for 2 weeks later. What are they looking for? Red, warmth, pain in the calf area, those type of things. Treatment usually consists of anticoagulant therapy and rest. Prevention involves early and frequent ambulation after delivery. So again, we're getting those C-section moms up right away as soon as we can, get them ambulating. That all helps prevent these DVTs. We want to observe for any complaints of leg pain or discomfort, especially in that calf area. Overdistension of the bladder is another postpartum care. So distension of the bladder occurs in the postpartum period due to residual effects of anesthesia and birth trauma with subsequent swelling of the urethra and perineum. So again, we have a lot of pressure down there from delivery or even C-section anesthesia that all promotes urinary retention. So bladder overdistension can affect uterine involution and increase that vaginal bleeding. So the bladder must be assessed frequently in early hours after birth. A full bladder causes the uterus to be displaced above the umbilicus and well to one side of the midline of the abdomen. So a displaced uterus, a boggy uterus, or a palpable bladder requires immediate nursing intervention. So we got to get that bladder empty so that we can get that uterus back into place. So management of overdistension of the bladder, the first priority is to assist the new mother to the bathroom and or offer a bedpan if she is unable to ambulate. But some other options that we might need to do, especially if they've had even if there's like a tear or if the anesthesia or anything like that or maybe we had to put a catheter in due to an epidural. Sometimes just if you can set them on the toilet and if you do some running water in the restroom or squeezing warm water from the peri bottle over the perineum, it can kind of stimulate them to void. Using a few drops of oil of peppermint in the toilet or bedpan, sometimes they say that helps with the voiding. They think the vapors help relax the muscles that control urination and may assist the patient to voiding. If these measures fail and the patient displays signs of an overdistended bladder and cannot void or is voiding just small amounts, you might have to catheterize to get that bladder empty. Again, a use of a bladder scanner can help determine how much is in there or if there's any residual after they feel like they have voided. Breastfeeding. So there's really 5 different nursing positions. There are very few circumstances in which a woman would not be able to produce milk, or even in these rare situations, there are still benefits of allowing the infant to suckle at the breast. So nurses should proactively refer such cases to lactation consultants if available, but support and encouragement for nurses and lactation specialists are very, very vital to ensuring early breastfeeding success. If you ask a mom, a lot of times breastfeeding is some of the most anxiety that she has of having a baby, just making sure that she can breastfeed. Primarily, nursing mothers should be taught proper breastfeeding technique and a latch on. This will promote effective suckling and emptying of the breast. Good positioning with pillow support to the back, neck, and arms will facilitate good latching techniques. And the mother should be taught to cradle, cross cradle, football, and do supine holds. So the classic breastfeeding position, the cradle, the baby's head is in the crook of your arm, so you can kind of see that's your one on the top left. And this is the most classic kind of position. You sit in the chair with supportive armrest or on a bed with lots of pillows. You rest your feet on a stool or other raised surface to avoid leaning downward toward the infant. So you don't want to hurt your back. You want the infant to kind of come to you. Hold the infant in your lap or on a pillow with the infant lying on his or her side facing you, and tuck the infant's arm under your own arm. You want to be able to support the infant's neck, spine, and bottom. And so that's kind of that cradle position. So again, you really want to flatten that breast when you go to get it in the baby's mouth, because that really promotes that nipple to get towards the back of that tongue and promotes a good latch on technique. Another one is what's called the cross cradle. If nursing from the right breast, you use your left arm and hold an arm to hold the infant. Okay. So just a little bit different technique. You rotate the infant's body to direct face you, and you guide the infant to the breast with your thumb and fingers behind the head and elbow and ears. Then there's also one that's called the football hold. You're going to tuck the infant under your arm on the same side that you're nursing from, like kind of just like a football. Position your baby at your side under your arm, facing you with her nose level with your nipple and her feet pointing towards your back. Another one is a supine hold. You support your back with several pillows while lying on your side. One under your head and shoulders and one between your knees. You're going to support your infant on a pillow if necessary. You'll cradle the head with your arm, and the newborn should be put to the breast as soon after delivery as possible, and therefore on demand. So you're going to a lot of times, as soon as we've given everything to the baby that we need to, it goes back to the mom. We promote that skin-to-skin contact, and we put them to breast just as soon as we can. Then after that, at least every 2 to 3 hours to establish a good milk supply. So we'll be bringing that baby back, even if it's in the nursery, about every 2 to 3 hours. And mothers should be taught to recognize early feeding cues in the infant and the nurse on demand. So something to really think about too is when baby is nursing, you will hear the mom say, "Man, I just feel like I got cramps really bad." Nursing stimulates that uterus to go and contract back into place. So again, it's all kind of that natural process that they'll be nursing and they'll be like, oh, I really feel like crampy. Yep. And sometimes we can help kind of deliver their medication around that time, like when we know the baby's going to be coming in to nurse, just kind of helping get some pain meds on board prior to them nursing. Because some women do get very, very crampy when they breastfeed. Um, some other things too with breastfeeding, the mother can be taught to use gentle massage starting at the axilla and working toward the nipple if needed to encourage like the let down reflex, which allows that milk to be released into that milk duct. So just massaging her own breast can promote this. The reflex is controlled by that prolactin and oxytocin, but also require maternal relaxation to be effective. Pain, stress, anxiety can interfere with, breastfeeding. This will cause the retention of milk within the milk gland, which can cause additional pain and anxiety. Most complications of breastfeeding can be avoided by good latching techniques, and that good latching is very much the key thing. Frequent feeds that are baby fed and not timed can also cause some of that. So we want to make sure get on a good regimen, make sure the baby's feeding on time. Sometimes, however, plug ducts or mastitis may occur, and the nurse should be able to differentiate these conditions. So plug ducts occur when the breast is not drained often enough. It is usually unilateral, so both breasts are being affected. It is not accompanied by flu-like symptoms. It presents as very tender area in the breast. Now, mastitis, on the other hand, is a breast infection that presents with localized pain in one area of the breast, which can be hardened and red. It is usually accompanied by a fever and flu-like symptoms and usually only involves one breast. It is often seen several weeks after hospital discharge. Poor milk drainage, maternal fatigue, stress, and poor hygiene can contribute to the possibility of infection. So treatment would include rest. We'd have to do antibiotics, analgesics, increased fluid intake, and frequent feedings or pumping to empty the breast. So again, mastitis usually affects one breast and is accompanied with fever and flu-like symptoms, where the plug duct only usually occurs like in both breasts and it doesn't have the flu-like symptoms. So maternal postpartum discharge teaching. You're going to, during your discharge teaching for the new mother should begin as soon after birth as possible and contain the following information. So the healthcare provider should be contacted for a temperature of 100.4 degrees or higher. If there's any change in that lochia, so excessive bleeding, passage of large clots, foul odor, or if it goes and it returns back to that bright red when it was brown before and now it's bright red, bleeding. If they have any calf pain, redness or tenderness, signs and symptoms of that DVT. If they have symptoms of a UTI, such as burning on urination, frequency, urgency, those type of things. If they have any problems with their episiotomy or C-section incision, so redness, swelling, drainage, lack of approximation, increase in pain. Signs and symptoms of breast infection, again, mastitis, red, hot, firm area on breast, you had a fever, you have flu-like symptoms. We want to make sure we're avoiding strenuous activity for 6 weeks and no driving or for 6 weeks post-cesarean. Again, no intercourse either. Too much activity may cause an increase in vaginal bleeding, especially in those early weeks after delivery. We want to schedule that 6-week follow-up. We want to make sure we're having perinatal care, shower rather than baths for those first weeks, perform perinatal hygiene before and after voiding and bowel movements. We want to use those topicals if needed, witch hazel pads, foams, hemorrhoid creams. No intercourse, no tampons or douching for 6 weeks. Continue prenatal vitamins with iron while we're breastfeeding. That needs to be included. We need to make sure we're taking in an extra 500 calories per day and with nutritious, well-balanced diet if we're breastfeeding. We want to wear a snug, well supportive bra. We want to avoid stimulation to the breast and use ice and analgesics if needed. So that's especially if you're not nursing. We want to make sure at that point that you have that tight bra on. We're not stimulating the breast. We can use ice for the engorgement or analgesics if needed. We want to make sure that we're reviewing the discharge medications and check all other medications with her provider. What should she restart on? Maybe she was on an antidepressant prior to. Do we restart her on that, or different medications too that might have been stopped during pregnancy? We want to make sure we review those signs and symptoms of postpartum depression and provide a list and contact of area support groups that are available. Make sure that we're including her family in on that teaching, and teaching of different things to look for with depression, anxiety, all those different things. So the main thing is just watching, and we got to provide good education so these patients are prepared to go home. So, and that is the end of the lecture. Thank you.